Hello, Basu this side. Do like and subscribe to our YouTube channel, and your support is very, very important to us. You guys have been great. Continue to support us. In today's episode, in Time Out with Basu, we have a very special friend, brother from another mother, partner in crime. Have had some wonderful time with this gentleman, and he's none other than Patrick Google Farad. Hey, Patrick, what's up? How are you?
Good, Basu. How you doing? All good?
All good, brother. How are you?
Excellent, thank you. Lovely here in Sydney this evening. Very nice.
Patrick, before we go further, our fans and followers would like to hear it from the horse's mouth. Please give a short bio about yourself, and we're all yours.
Boy, oh boy.
I know it all. They need to know.
All right. I'm a clinical physiotherapist with, I'd have to say, over 30 years of experience now. I've primarily worked in sports, but have had a few clinics of my own. So I've also worked a lot with, how will I call them, normal people, which is great. As you know, working with sports people has its rewards, but it also has its problems, and it's nice to get back to see normal people as well. Like I said, I've been a clinical physiotherapist past 30 years, but I've certainly changed direction in the last 12 months or so, where I'm at the moment working with Delhi Capitals in the IPL for 3 months a year, and the other 9 months a year I'm pursuing my research, looking at a better way to improve and manage lower back injuries in sport. So most of my time is spent doing that at the moment. I'm really, really enjoying it, and hopefully we'll come out with some good things.
Okay, for starters, Patrick, I'm going to serve you the soup now. Please name all the members of the band Traveling Wilburys.
Oh, geez. Okay. George Harrison, Bob Dylan, Tom Petty, Jeff Lynne, and Roy Orbison. Unfortunately, 3 of them are no longer with us. So it's only, Bob and Jeff left.
What a band, what a band.
Magnificent.
What is the capital of Senegal, Patrick?
Oh, that's Dakar.
Ivory Coast.
Up until 1983, that was Abidjan, but now it's Yamoussoukro.
Ladies and gentlemen, that's why I call him Patrick Google Farad. He knows everything. Oh my God. Patrick, I'm going to put you on the firing line. We have a lot of questions for you. And young physiotherapists and trainers will benefit immensely. And we're going to pick your brain, and we're going to start. Are you ready?
Ready to go.
Okay, imagine you're Steven Spielberg. Seen the movie Back to the Future. You go back in timeline. You go to 2010. You, Patrick Farad, as a therapist, what you would have done differently?
That's a good question. I tend not to be someone who looks back on any decision that I made in the past and think of what would have happened if I'd done it differently, because for me, that's not a particularly productive way to work. But I'll say this, okay? As I mentioned earlier, in July last year, I enrolled into a PhD at University of Technology in Sydney. And in this, I'm investigating improved methods for the prevention and management of lower back injuries in sport. We're starting with cricket, but we're eventually going to move to sports like diving, ballet, dancing, tennis, many, many sports we're going to look at. Now, the reason I'm researching this is, honestly, in my mind, I think the models that we've based our strategies for preventing and managing these injuries is flawed in many aspects, okay? And whilst a lot of this research has been done by people who've worked very diligently, very honestly, and with the best of intentions, I think there's a better way of doing it. So rather than just criticize people for the work they've done, I think it's important to find better ways of doing things. So to answer your question in a roundabout way, if I could turn the clock back to 10 years, 2010, 2011, the one thing I would have done is commence this sort of research earlier. It's only natural, I suppose, but it's very easy to get caught up in work only for financial rewards and providing and money. But unfortunately, that only gets you so far. And I think if you've been working in any field for a long time, then I think it's very important to leave a legacy and ensure that that discipline that you specialize in, that you work in, has improved from the time that you started working in it. So, my humble opinion is your time to develop your legacy is shorter than what you think. So if you want to do it sooner than later.
Patrick Farah talks about legacy, and I'm sure all great men think alike. Patrick, what's your secret sauce? You've been a successful therapist. What's your secret sauce? What kept you going, and how did you reach the pinnacle?
I'm not sure about the secret to success, but I can tell you at the start what the secret to failure is. Okay.
I like this.
And then I'll try and get there. The secret to failure for me is trying to please everyone 100% of the time. So if you're working as a strength and conditioning coach, a physiotherapist in a clinic with elite athletes or within a professional sporting environment, you're probably going to experience and be subject to competing interests and demands from athletes, team owners, administrators, coaches, fellow sports science and medicine professionals. Okay. One or more of these people may have interests and preferred outcomes that are very different to how you would best manage a situation or how you would best manage an individual's recovery or training. Okay, so in these situations, I think it's very important that you set, stick, and maintain, very importantly, the expectations that you have set for yourself in the standard of care and intervention that you practice, and even more importantly, the principles and ethics that guide your communication, decision makings, and recommendations to one or more of these stakeholders that I spoke about. Okay. If there was a key to success, I would say the following. As sports science and sports medicine professionals, we need to understand and always remember that we are in the business of dealing with people. We're dealing with their health, we're dealing with their livelihoods. I've got nothing against engineers or lawyers or accountants, but it's fine for them to operate on this level that isn't personal. But for us, we can't do that. But at the same time, when we are dealing at a personal level with these individuals, we have to keep in mind that it is so important that we are objective and consistent in our decision making, and that we treat every individual equally and based upon the best medical and scientific knowledge that's available. So in a team environment, that might mean, treating the first year rookie the same as you're going to treat someone like a Virat Kohli or Rohit Sharma. Okay. We need to be true to that athlete and that patient that we look after, but most importantly, we need to be true to ourselves. So if we do that, I think you're going to be successful more times than not.
Very well said. I mean, that is a key point for young trainers and physios. Treat everybody the same. Very, the next thing is, you've been in this for so long. There must have been one most challenging case or one condition. And if you can put your bloody finger in one place and say, that bloody case was bloody challenging, I couldn't sleep for a couple of days. It really took me. I mean, you must be having a lot of experiences, but name one for us.
Oh, the one I probably find most challenging, and I obviously can't mention the athlete's name, but around
Please,
15,
no.
I dealt with a professional athlete who was experiencing very high level lumbar spine and lower limb pain. That was the result of a very large L5-S1 intervertebral disc extrusion. So he underwent a fairly lengthy period of conservative treatment for that in my mind was based upon the best available evidence at the time, but unfortunately this failed. So following this, myself and his medical team, we made a joint decision for him to undergo a lumbar microdiscectomy. And literally the morning after he had the procedure done, he woke with no pain, no symptoms. So this provided complete and rapid improvement in his signs and symptoms. After this, he underwent a 4-month period of rehabilitation and graduated return to activity. And a few weeks after that, he returned to professional sport. But unfortunately, 2 months after that, he sustained a recurrence of his condition. And the second time was worse than the first. So we returned to the same surgeon that performed the initial procedure, and he recommended a second microdiscectomy. And
that must have been.
I'm a bit concerned about this. So we went and saw another surgeon who also recommended a second microdiscectomy. And now, in the background, the assistant physio that I had with me and the sports physician who was with me at the time, we all got together, did a very large amount of reading and investigating, and looked at likely recurrence rates and the likelihood of a return to professional sport after a second microdiscectomy. And the result we came up with was the likelihood wasn't that good for not having a recurrence or getting back to sport. So we started to investigate the suitability of a lumbar disc replacement, which was a fairly novel and new procedure at the time. So this athlete consulted a surgeon in another city in Australia regarding this, and a decision was made to go ahead with the replacement. The surgery proved to be successful following a 6-month rehabilitation period, and the athlete did not experience any recurrence of his condition, was able to return to his pre-level sport and back to international level sport. So for me, my takeaway from that was, whilst it's important to trust and respect the opinions of professionals that you deal with, it's also fine to respectfully disagree with them, okay? If the science and the evidence suggests that an alternative course of treatment or management is likely to give that patient or the athlete you're working with an improved outcome, then you should follow that, okay? If a form of management is not working, there's usually a very good reason for this, okay? So if we are put into these situations, it's up to us to find a reason why an outcome has occurred and to find a better way to do things. And, sometimes that means, again, not making everyone happy, but at the end of the day, as I said, we need to be true to our patient, or our athlete, and true to ourselves.
Oh, fantastic. Very well said, Patrick. I mean, when you have the challenge, you need to stick to your guns, stick to your ethics, and you need to dig deep. Oh my God, I mean, it must have been challenging.
And the thing is now, there's so much information out there. The world is a so much smaller place in terms of knowledge than what it was 15 or 20 years ago.
Absolutely.
It is very, very easy now to connect professionally with your colleagues and your peers. And most people who are interested in the betterment of their profession and the betterment of sports science and sports medicine are very, very happy to share their expertise and their ideas. So there's a lot out there.
Paddy, your take on hands-on therapy. I mean, how much is it required? And everything can't be hands-on, obviously.
I think that's good. I do agree with you, but I also think hands-on techniques in physiotherapy have gained a bad reputation in recent times because oftentimes they're misused and overused. Okay, like, for example, hands-on techniques can be very valuable in the management of acute conditions, particularly in the management of recent onset and acute neck and back pain. I think the value of hands-on techniques, when they're used early in a condition, they often help people to move in a much less restricted manner than if they were not used. And once people start to move, as we know, they generally feel better. Once people start to move, they walk, they run, they go to the gym, they swim, whatever. And that's what seems to help them. I think hands-on techniques get a bad name because unfortunately lots of practitioners tend to rely on them in the management of long-term and chronic and recurrent conditions. And they use it a lot for maintenance type work that athletes often request or require. So we'll often see an athlete, come up to you and say, release my back, release my hamstring, release my...
We would have heard it a million times, Paddy.
But for example, if you look at something like hamstring muscle strain injury, okay? There's a lot of good work and a lot of reasonably high level evidence out there now that suggests you can improve hamstring muscle injury strain and recurrence rates with the whole combination of strength exercises that help improve things like, basic length of the long head of biceps femoris, or help improve isometric strength, or help improve eccentric strength of the hamstring muscle group. And you and I have spoken about this in the past. We also know now that, if you do regular bursts of high intensity running, you get very high amounts of, muscle activity through your long head of biceps femoris. And this is in fact protective for, future or recurrent hamstring strain. So these things cannot be achieved with maintenance or soft tissue work, okay? So, when your athlete with a recurrent muscle strain, a recurrent condition, asks you to do some soft tissue or release work, or help him or her to stretch and try and prevent or improve this recurrent injury, then I think you need to look at the evidence and point that athlete in a different direction.
While in this topic, something else popped in my head. Core stability.
Wow.
Everybody talks about core stability. You need to spell it out, please.
You know what? 20 years ago, and it's not about believing or not believing in core stability, but 20 years ago, I very much thought that, the local and global muscle systems that people talk about, and the subsystems, the active and passive and neural subsystems that Panjabi, who Don't get me wrong, Panjabi, Manohar Panjabi is a brilliant orthopedic surgeon who was also a mechanical engineer. He's a brilliant man. But, you know, for me, all of this is based around the maintenance of a neutral spine and the use of feed-forward mechanisms for activation of transverse abdominis. I think there is enough evidence out there now that suggests that if this is occurring, it's only occurring to a very small degree. If it is occurring, I think it's probably only going to help sedentary population. You know, it's the sort of thing, and I love my mother, don't take this the wrong way. My mother does a bit of housework and does a bit of ironing at home. She's almost 80 years old, God bless her. But that's the sort of thing that may help her. But, you know, for people engaged in lifting, doing, you know, active people, sports people, first question I have is, number one, how much time do they actually spend in neutral spine? A, very little. And if you're telling me that little muscle, so deep, and that little multifidus, which most people cannot even activate, is going to help your outcomes with lower back pain and recurrent injury, I would say I think you need to be thinking about something else. So for me, I think the horse has run and the horse has bolted and the race has been run and the race has been lost, I think, for core stability. Proving that is a very, very different matter. You know, you look anecdotally at the people who tend to, I'll call the word engage, activate, use their core to hold their spinal column, hold themselves stiff or rigid, let's call it, when they're doing activity. Anecdotally, and some research has shown this recently, they tend to be people that actually experience more lower back pain than those people who tend not to try and stiffen and make rigid that core. So oftentimes when you're trying to do this, you're actually compressing your facet joints, compressing your disc, compressing your vertebra. Oftentimes you are creating more problems than what you are solving. Now, I know for a fact, I'm not saying because it's me, but there are a lot of physiotherapists in the Western world now who, instead of having 1 and 2 bedroom houses, have 5 bedroom houses because of Pilates and because of core stability. I'm not having a go at Pilates practitioners, okay? I think some of the work that Pilates practitioners do is amazing, but the method that athletes and patients and devotees of Pilates, the methods they use to engage these deep muscles and engage these core muscles has actually made them more rigid and made them more vulnerable to injury.
I mean, Patrick clearly says, don't worry about the tools, worry about the actual expertise. I mean, the other day I was talking to Chris, he was telling the same, GPS is fine, but that cannot make you run faster. I mean,
Agree.
Likewise, I mean, core stability, there is a place, but it is not the be all and end all. And
Agree.
we're talking about Pilates, core stability, and all this Mickey Mouse stuff, but we need to understand where to mix it and how. That's the most
Correct.
important thing.
I agree.
And very well, there's been a huge hue and cry about leg extension and ACL reconstruction of late. And how do you conclude that debate, and what's your take?
If you look at the early work, and this was based on work from 1985, the original work that said, if you do open kinetic chain strength work, also known as leg extension, that you are going to increase the stretch and the load on an ACL, and you're going to increase compression forces in the patellofemoral joint. Now, that study was based on a method of leg extension that is no longer used, using a cable and using it at a very distal point. So the results of that study probably aren't applicable to open chain and leg extension work that is done nowadays, okay? Taking that out of the equation, there was a very, very good systematic review that was done a couple of years ago by Perriman. I think it was 2018 in the Journal of Orthopedic Sports Physical Therapy, JOSPT. And I encourage all of your listeners to have a read of this. And I think this was a bit of an eye-opener for a lot of people around this argument that the addition of open kinetic chain strength or leg extensions after an ACL reconstruction is going to increase laxity of the grafted ligament, cause a lot of problems, cause pain, cause swelling, etc. Okay, so this review concluded that when you add leg extension after 6 weeks following your surgery, that the between groups, between open chain and closed chain, the differences in laxity were less than the detection threshold. Now, the detection threshold for laxity when you're doing Lockman's test or when you do it instrumented is 2 millimeters. So this study concluded that if you start leg extension exercises after 6 weeks, so let's say 7, 8 weeks after surgery, that it made no meaningful difference to your laxity, okay? And when this study looked at patients adding these exercises in less than 6 weeks after surgery, it basically found the same thing. So a lot of people have jumped up and down and said, yep, let's start doing open chain exercises straight after surgery. Now, I would say with this study, and it's like every study, you really need to look closely at the methodology and you really need to look closely at the subjects and the subgroups and how they're divided. I'll say 2 things about that study. Firstly, those patients that had patella tendon grafts for their ACL were found to be less vulnerable with the addition of open chain leg extension exercises than those patients who had hamstring tendon grafts. Okay, and you must remember nowadays most ACL constructions are done with hamstring grafts for lots of reasons. I'm being cynical. The major reason that people talk about why they do hamstring tendon grafts is they say there's less morbidity after the surgery. Okay, there's less swelling, there's less pain, they require less rehab. Most of them get back quickly. But, you know, I'm a big fan in life. You don't get anything without paying for it. In my humble opinion, I think hamstring tendon grafts, and some of the researchers also back this up, may be a little bit more unstable in the long term than patella tendon grafts, okay? If I put my cynical hat on, it will say to me that a patella tendon graft takes a surgeon twice as long to do than a hamstring tendon graft, but he's going to make the same money from them, so he can do double the amount of hamstring tendon grafts in a surgical session. We're not going to talk too much about that. Okay. We also need to remember that, you know, ACL strain is 0% when you do open chain quads work, leg extensions between 60 and 90 degrees of knee flexion.
Absolutely.
And we know it reaches its peak strain between 0 and 30 degrees of knee extension. So my take on it is this. So what's the lesser of the 2 evils? Are you better off? Are you going to increase your risk of recurrence of an ACL injury more because of poor quadriceps strength? Or are you going to increase it more by doing early leg extension? It's a hard one. So my interpretation would be to compromise. So what I would do is have your patient after the ACL surgery do supervised restricted range of movement, restricted range of motion, leg extensions between 45 and 90 degrees from 6 weeks after the ACL surgery up to around 12 weeks. And then you could look at introducing full range of motion knee extension from about 12 weeks after surgery. That's for hamstring tendon grafts. If they had a patella tendon graft done, you could probably look at 4 weeks and 10 weeks. So
but most of the leg extension machines are designed in that direction nowadays, Paddy.
Yes, correct. So most of them are fairly safe. But I would probably not do a lot of it prior to the 6 week mark, particularly if they had a hamstring tendon done. If they had a patella tendon done, I would definitely look at doing it earlier.
And what about a guy who's not opted for surgery? Let's say that he's not opted for operation and he wants to still go ahead with this conservative management. And
I would probably,
maybe after 12 weeks, he's fine, he's pain free, and he's found his range of motion.
I would, you know, we know that we think that an ACL doesn't heal itself. There's some people saying that it possibly does now, but I would probably stick to the same sorts of timelines. But I would certainly look at introducing leg extensions after anyone who's had an ACL reconstruction, because I think there's a lot of evidence now that suggests that, you know, it is very, very difficult to get your quadriceps bulk and your quadriceps strength and your quadriceps power back with just closed chain exercises. You are going to need
a little bit of isolation.
Yes, you do.
I mean, very interesting. I mean, it has sort of been a confirmation bias for so many years, and things are now coming into light, and it's clearing up. I mean, the message from you is pretty clear for the young therapists and trainers. Superb.
Yeah, it's often the way.
Sorry, go ahead.
I was going to say, it's often the way that we do things in the field and then they become confirmed by research subsequently. So that often happens. That's a nice thing.
Paddy, Jill Cook. I mean, we all know that Jill Cook and tendinopathy are probably married to each other, and her opinion on tendinopathy is valued by many. I mean, Jill Cook feels that most of the patellar tendinopathy you see are not necessarily patellar tendinopathy. It can be anterior knee pain. Similarly, most of the calf pains you see are not necessarily calf pain. It can be a tendon Achilles issues and stuff like that. And I'm sure you're going to have a go at that. And we're all yes.
Maybe not, but I'll just say a few things. I think Jill Cook's an amazing researcher. She's been incredible for the physiotherapy profession, and she has provided an amazing amount of very practical and simple, and I don't mean simple in a bad way, simple and easy to understand interventions for sports science, sports medicine professionals for the management of tendon problems. I think what she's talking about when she says that lots of people with patellar tendinopathy don't have anything to do with the tendon, I think she's talking about a whole range of people who are diagnosed with patellar tendon disorders actually have issues away from the tendon. And believe it or not, I actually agree with this, okay? And the reason I agree with this is where our clinical reasoning comes into play. Clinical reasoning for me is the foundation of problem solving in physiotherapy and sports medicine. I think it's very important to remember who the core group of people who suffer with patellar tendinopathy is, okay? And all of the research suggests that the subgroup of patients who damage their patellar tendon are males who do it in their adolescent years. Now, that doesn't mean that they develop symptoms in their adolescent years, but it seems to be that they undergo structural alterations and structural damage to their patellar tendon in their adolescence, okay? And the reason we think this is the case is because males and females, their musculoskeletal systems mature at different stages and different ages, okay? So in males, we know that the proximal portion of the patellar tendon, for it to be strong, it has to fuse properly onto its inferior patellar attachment, okay? But we know in young males, it doesn't fuse onto its inferior patellar attachment until very late in puberty, okay? And prior to this, if that young male has been involved in a lot of sport, they can do a lot of damage to that patellar tendon structure and that interface between the inferior part of the patella and the tendon that attaches to it. Now, we most often see this happening 1 or 2 years after peak height velocity, which we know is going to be around the age of 15 or 16 in males and 12 or 13 in females. Now, we know that the skeletal systems of females tend to mature slightly earlier than those of males. And without being discriminatory, we're all equal here. Many females in all parts of the world don't subject their lower body to the same amount of loading and intensity of loading, okay, as what young males do, okay? So with this in mind, most young female athletes who present with what we think is often patellar tendon pain, okay, will normally have patellofemoral pain, anterior knee pain, unless they're a super elite athlete, okay? And the 3 reasons for this, I think, is the discrepancy you see. You don't see that same discrepancy between maturity of the proximal part of the patellar tendon and fusing onto the patella in females that you see in males with the amount of loading that they do. Secondly, because females have this wider pelvis, and as a result of that, they have increased femoral internal rotation in comparison to males. So generally they will have different mechanics and different contributing factors to pain that is around the knee. Okay, so when you look at patellofemoral pain, it's normally due to abnormal mechanics, and those mechanics are driven from, depending on whose work you read and depending on your bias, are driven primarily from the hip and from the foot. Whereas patellar tendon problems are more about errors in loading. So, how you're dealing with the loads of landing, and what the influence of the ankle joint and how much dorsiflexion the ankle has, and subsequently how much calf muscle strength you have and how much quadriceps strength you have to be able to absorb and store that energy on loading. So I think she has a good point. And what we need to remember when we're diagnosing patellar tendinopathy, that there are two very clear diagnostic criteria in the diagnosis of patellar tendon. And they are, firstly, that the pain should be localized to the tendon and stay localized to the tendon with activity, okay? And secondly, and most importantly, the pain should increase as the load on the tendon increases, okay? And the two major differential diagnoses we see are patellofemoral joint pain and what we call inferior fat pad or Hoffer's fat pad dysfunction, okay? So, you know, with patellofemoral joint pain, you will often see that aggravated with stairs, okay? Particularly downstairs. It's often worse with knee flexion, particularly deep knee flexion. Patellofemoral joint pain tends not to be associated with swelling. It doesn't have a lot of localized tenderness. And people who have patellofemoral pain they tend to like to be in knee extension. Whereas, you know, people you see with this inferior or Hoffer's fat pad pain often will have some localized tenderness at the inferior patellar pole. They'll have localized swelling. They like to stand and squat and like to be in knee flexion, and they don't like knee extension. Okay? As I said, patellar tendinopathy very much should be localized to the area. Sometimes they're sore on palpation, but palpation is definitely not a criteria for diagnosing. The big thing is pain should increase in that area as
Absolutely. I mean, also interestingly, we notice that athletes who have not trained very well in the developmental stage and they have not done basic plyometrics, I mean, they tend to have deficiency in tendon strength levels, and tendons generally take longer time to train than the muscles.
Agreed.
And it is very important not to miss this particular small
totally.
portion of their development.
Very true, but a lot of people, they need underlying strength, okay, before they do plyometrics. For me, plyometrics, you need three things. You need a good ankle range of motion that you utilize, okay? You need good calf strength because we know your calf and your ankle absorb around 60% of your vertical ground reaction force, and you need good eccentric quad strength, good eccentric quad activity, okay? So, yeah, with regards, you're right, with regards to the Achilles and the calf, I think, you know, if you want to, what Jill Cook's talking about, I think it's important to understand the anatomy of the Achilles tendon and its relationship with the calf muscle complex.
Absolutely.
And if you look at the mid portion of the deeper fibers and the deeper surface of the Achilles, it's comprised of very long fascicles. The Achilles is a very, very long tendon, okay? And a lot of those fascicles are intricately linked to the soleus and intricately linked to the soleus much higher than what you think, okay? And this area where these Achilles fibers join with the calf has been shown to be the area of the Achilles that undergoes very large amount of displacement, a very large load, and large changes in direction of force, okay? And these appear to be the things that are associated with tendinopathy. So a lot of people like Seth O'Neill's very, very good practitioner in England with talks about the importance of the function of the calf and the importance of soleus strength and function in the prevention and management of Achilles tendon problems. And yes, I agree totally. But for me, that also raises the issue of the number of injuries that are diagnosed as soleus strains or soleus tears that may actually have their origin in the Achilles. Now, let's look at what happened last year. I think it's about 15 months ago now, is it? The famous Kevin Durant case, basketballer with Golden State Warriors, where the medical team of Golden State was criticised for rushing this player back from what they said was a calf strain, and then subsequently saw him, I think it was game 5 of the playoffs, so trying to get to game 6, subsequently saw him suffering a rupture of his Achilles tendon the day he came back, and he was obviously in the required surgery and traded, and it was an absolute disaster for the player, and it was a public relations disaster for Golden State Warriors. Now, you know, without trying, you know, I'm not in the business of trying to defend the medical stuff there, but, you know, in my humble opinion, I don't think there is any way on earth they would have got him to play if they thought that there was any possibility in him rupturing that Achilles tendon, you know.
Absolutely.
Yeah, my take on it is this, you know, radiology may well have shown a problem in the distal calf rather than the Achilles, but there was obviously something happening in the Achilles tendon. There was obviously high scale, high grade degeneration that was taking place in the tendon. But some of these things, unfortunately, are below the threshold of what radiology can detect. So, our radiology, whilst we need to rely on it, isn't perfect.
The radiologist is an important cog in the wheel. I've seen it with you so many times, and that actually alters your whole decision making and how important is the part of the team. Amazing.
I think I think the radiologist is very important. I think we empower our radiologists as well when, if we're sending someone for a scan, okay, we're sending someone for a scan, we just don't say back pain, please diagnose.
Specific.
I think you give them a good history. You give them 1, 2, or 3, a likely diagnosis, secondary diagnosis, and a possible third diagnosis, and you talk to them about their history and mechanism of injury, okay, and ask them to please consider these things. I think that is very, very important. There is a school of thought now, and I'm not sure it's going to happen, that suggests that radiologists need to and should actually clinically examine their patient before they go into
Oh, that's interesting.
Yeah, into a radiological investigation. So it's interesting.
Paddy, differences in disc and facet joint. We have spoken about it a million times. Annulus tears, and not all discs are flexion oriented. Not all facet joint problems are extension oriented. And we're talking about the superior facet, inferior facet, and facet locks and stuff like that. And when do we administer injections for the athlete? And this is a sort of a puzzle, and this piece has to have a decent understanding by any professional who's dealing with the athlete, whether it's a trainer or the physio. Please throw enough light on this so that people are totally aware of what's happening.
This is an interesting question. For me, whilst there are differences in the presentation of disc and facet problems, there's certainly some overlap. And a lot of people experience these problems together in a manner, and that's happened with so many other regions of the body. Like, for instance, with people with adductor region pain, they may have a hip labral tear or possibly some impingement in the hip along with an adductor tendon strain or an adductor tendinopathy. And the same thing happens in the lumbar spine. Very rarely do these problems occur in isolation. In saying that, though, I think there are a few things that differentiate disc pain from facet joint pain. And for me, one of the big ones is the presence of early morning symptoms. So people being sore and stiff, especially when they're waking up. So this is the case because when you sleep, you're offloading your spine for however long you sleep, 6 to 8 hours. And when you're lying down, non-weight bearing, your disc undergoes a rehydration process to restore the fluid that's lost throughout the day when we're up and weight bearing, okay? So this rehydration process leads to the disc occupying more space within the intervertebral joints, okay? And if you have a disc bulge, it will occupy relatively more of your spinal canal. Okay, so if you have a disc bulge, they'll often feel worse in the morning. In addition to this, cough or sneeze can aggravate disc symptoms because they increase intradiscal pressure, okay? And often disc-related pain will cause referred symptoms into the gluteal area or into the leg. And that can be the front of the leg, the back of the leg, the gluteal area, the inside of the leg, depending upon the level that is affected. So, these symptoms can be either pain or tightness, pins and needles, tingling, numbness, weakness in the muscles of the motor distribution of the nerve roots that may be irritated or compressed adjacent to an affected disc. And if there is a reasonable amount of compression, you can often see a loss of the L3 quadricep, patella tendon, or the S1 Achilles tendon reflex, okay? And, if you're trying to differentiate facet joint problems from other spinal conditions, most of the time, facet joint problems, or let's call them facet joint dysfunctions, will usually present as opening or closing type problems. So what I mean by that is there are often patterns of pain associated with facet joints that are either combined or couple movements. So, an example I can give is If someone presents with left-sided low back pain and have an increase in pain with the individual motions of lumbar flexion, lumbar side flexion to the right, and lumbar rotation to the right, and when you combine those movements, you actually increase their pain even further, then you would suspect a left-sided facet joint dysfunction that is not allowing opening of that joint. Okay, so you would confirm that by putting your hands on the patient, palpating, getting the patient to move into these positions, and you will feel one joint on one side opening into flexion, you won't feel the other side opening, okay? So these procedures are very well described by an English osteopath whose work I strongly suggest people to look at by the name of John Gibbons. He's got some stuff on YouTube. He's a very, very good teacher, and I think he explains these concepts very well. You know, conversely, if a patient presents with left-sided back pain and they had increased pain with individual and combined movements of lumbar extension, lumbar side flexion to the left and lumbar rotation to the left, then you're suspecting a left-sided facet joint dysfunction that doesn't allow closing of that joint. So the treatment approaches to these two dysfunctions are very different. Now, I'll add on to that, you know, when we look at cricketers, we often, you know, the big thing we don't want to see with cricketers are what we call pars interarticularis and pedicle stress fractures. And these can often present in a similar manner to closing type lumbar facet joint dysfunctions. But there are a couple of differences in lumbar facet joint dysfunctions. People will often improve as you load them and as they go through movement, okay? With a posterior element, pars interarticularis or pedicle bone stress injury, they will get worse with loading, okay? And secondly, you will often see with these closing pattern, something that's a little bit irregular with the closing pattern itself. It doesn't seem to be as regular as what you see with facet joint pain. Now, facet joint pain is often quite easy to palpate. Pars interarticularis or pedicle related pain isn't that easy to palpate. Now, you asked me about disc problems and flexion and extension. If you'd asked me this 15 years ago, I would have certainly said 99%. I would probably said 100% of disc problems get worse with flexion. However, you know, since the advent of dynamic MRI, this has changed our opinion. So dynamic MRI, so instead of people laying down supine in an MRI machine, now we can have people in standing, and we can have people going from a standing neutral position into lumbar extension and the standing neutral position into lumbar flexion. So there was a very, very good study done. It was around 12, 13 years ago by Zhao, I think it was, in the journal Spine. And they looked at over 500 patients who had various sized disc protrusions, excrusions, herniations, call them what you like, using upright MRI. So they examined these spines in standing in neutral, and they moved them into flexion and moved them into extension. Now, this study showed that for all sizes of disc protrusions found on the MRI in the neutral position, that a higher number of these disc protrusions actually increased in size when people moved into lumbar extension rather than when they moved into flexion. So we're not really sure about the mechanism of why this happens, why certain disc protrusions increase with extension and in other people they increase with flexion. But my advice would be you treat every case individually, okay? You treat according to that patient's response to flexion and extension being used as treatment techniques. You know, I think it's simplistic. I think it's dangerous to just categorize disc issues as being primarily related to flexion and facet joint issues as being primarily related to extension. They certainly work on both ends of the spectrum. Now, in addition to this, you look at people who have annular tears and they will often develop pain in radiation. But these annular tears are difficult to diagnose because they're often characterized. You look at the MRIs, you look at these sagittal T2 and these axial T2 weighted images on MRIs, you see these white spots, what they call high intensity zones, but you know, these are often asymptomatic. So these
opaque
really need to be married up with a very, very good clinical examination. They need to be married up with a very good subjective examination, finding when people are getting sore. You also asked on the question of whether you should be injecting for these problems. Put it this way.
I mean, that's a big decision, when to inject.
Intervention in the form of an injection should only occur after a reasonable period of conservative treatment, and whether that conservative treatment has failed. And the exception I would say to that is if there's a large extruded, or particularly if there's a large separated or what we call sequestrated disc fragment. You know, we know if a piece of the L5 disc breaks off the rest of the disc, and we look at the anatomy, you look at where the L5 and S1 nerve roots sit, a little piece of disc will often sit in between those two nerve roots if it's come off the L5 disc. You know, that's something that's often not going to settle down quickly. It's something that hopefully the body will reabsorb in time, but before it reabsorbs it, it's really going to irritate these nerve roots. So, you know, there's definitely a case, I think, for those sorts of problems where you would look at an injection. So there's obviously several types of injections that are used in the management of disc problems. You know, the first of these is what we call a nerve root sleeve injection. So that's a guided injection using local anesthetic and using a corticosteroid. And this is normally performed by a specialist under radiological guidance into the sleeve of an inflamed or irritated nerve root, okay? And that is often used to help settle peripheral symptoms, so leg pain, pins and needles weakness, those sorts of things. Now, these injections tend to be effective for people that have a lot of leg pain or peripheral symptoms, but they don't seem to be as effective in the management of patients that have disc-related low back pain, okay? So there's a fair bit of evidence now that suggests that disc problems that manifest themselves as primarily localized lower back pain, okay, probably respond better to what we call a guided epidural injection. So that's, again, using local anesthetic and cortisone and putting that into the epidural space. Now,
you take a shotgun, but that's
so it's probably not as technically demanding. Now, shotgun's a good word because, you know, there's probably a proportion of specialists who will inject one or both. So they'll do a nerve root sleeve injection and an epidural injection to cover both bases. And some of them, while they're there, will often inject one or two facet joints adjacent and close to where that nerve root is. And, you know, whilst by many purists and people who are really looking for approaching the identification of the source of symptoms, a lot of interventional specialists will say, hold on, I've got this patient in a sterile, controlled environment. They're in a relaxed position, particularly if that patient has had a long history of pain, particularly if the pain is quite severe. They will often feel they owe that patient the best possible chance of having an improvement in their symptoms by injecting several structures, particularly, you know, if it's safe to do. In saying that, there's probably a limit as to how many injections people should have, particularly into a facet joint, because, you know, with a facet joint, you're looking into a small joint that has a thin capsule. And if you're insulting that capsule repeatedly with a needle, it's probably not the best thing for the integrity and the stability of the capsular structure in the long term. This is why I like, you know, practitioners to go along, if possible, to go along with their patients for a guided injection. For a couple of reasons. One, you know, if the radiologist or the interventional specialist is doing the injection properly, they will often assess the patient beforehand, look at certain movements that give them pain, inject that joint with the local anesthetic and the corticosteroid. Okay, and if it helps their symptoms, bang, they know they've hit the right spot. But secondly, you know, if they're getting that injection into the joint, and it's very difficult to get the needle into the joint, you know, either because the joint is very narrow or because the joint is very degenerative and scarred. You know, putting a needle into that sort of joint, particularly one that's probably scarred, it's probably not the sort of thing you want to do repeatedly. It probably will cause some damage to the capsule in the long term. So you need to be careful with them.
Lovely explanation, Paddy. Lovely. I mean, it opens many sort of ideas for young therapists, and they can look at a wider horizon, and I'm sure this will help them aid in their decision making. Paddy, I mean, you've seen many trainers across the world. One message to trainers, SNCs across the world? We'll come to the physios next.
Geez, I've got a few pieces of advice. My first is to understand running. Sounds crazy, this, but You know, invariably, most sports revolve around running, and it's the core skill that most athletes in any sport require. So as a strength and conditioning coach, you need to understand the mechanics of what helps someone to run quickly and efficiently, okay? And you probably need to understand the mechanics of running that are likely to injure an athlete, okay? Fortunately, if you help someone run more efficiently, then you're probably helping them to become less likely to be injured, okay? And I've said this over and over again. The best strength and conditioning coaches I've worked with have all been ex-running athletes, okay? They understand what it takes to make a runner efficient and resilient. Now, if you're not a runner, that doesn't mean you can't be a good strength and conditioning coach, okay? If you're not a runner, my advice is this: go down to your local athletics track, watch the drills that the athletics coach puts his or her athletes through, spend time with that athletics coach, okay? These drills will likely be some of the most specific and effective prevention and rehab drills that your athlete or your patient in the clinic can perform, okay? I'll give the same advice to young physiotherapists that see a lot of running related injuries and work with sport. Go to the athletics track, watch what the athletics coach is doing, spend time with them. Okay, that's the first bit of advice I would give. Probably the most important advice I'd give is to understand what you're good at and challenge yourself. Okay, understand your context, okay? Early on in your career, identify what you enjoy, identify what you're good at, and pursue this, okay? Once you've got a strength and conditioning qualification, the world has changed a lot in the last few years. It opens you up to the whole world of sports science nowadays, okay? That's a very multidisciplinary field, okay? So it's important to diversify your field of expertise because there's so many opportunities outside of being a strength and conditioning coach. You work in the fields of exercise physiology, biomechanics. There are courses now where, you know, people who've done sports science or strength and conditioning courses can work on becoming managers of high performance teams within sport, okay? So to be able to do that, you're gonna have to get yourself out there. You've got to investigate, have to be very open to explore what's out there. And there's a mountain of information out there, okay? There's scientific journals, there's blogs, there's podcasts like this one even, there's YouTube channels, there's experts in so many fields that you can hear talk, okay? It may also even mean going back to university. This is going to sound silly, but this for me is also so important. Improve how you communicate, okay? Get better at creating reporting systems that include different levels of communication to the different people that will need to receive it, okay?
Absolutely.
Make sure you are able to communicate in practical terms what you find and what you recommend. Remember, you're dealing with coaches, athletes, physios, doctors, parents, okay? You need to be able to communicate well with all of these groups in very different ways, okay? You need to develop processes to speed up how you analyze your data that you collect and that you act upon, okay? And when I talk about data, yeah, monitoring is very important, but you need to be very beware, okay, of the tsunami of data that can come your way with monitoring. You spoke about it earlier. We have all these toys and all of these tools now, GPS units, GymAwares, so many things, 2D motion analysis.
Not bored.
It's everything's out there. Nordboard. There are so many different bits of technology out there nowadays to help monitor the well-being and help improve the performance of athletes. Okay, this can give us an enormous amount of information, sometimes too much. Okay, some of this information is useful, some of it isn't. Okay, I think it's really important to initially measure what matters most, and from then evolve and improve and expand your processes for collecting and using data. Now, please remember, if you can't act upon the data that you're collecting, if you can't do anything with it, there's no point collecting it. Okay? There is no point in collecting data unless you can use it to inform your decision making. Okay?
Absolutely. I mean, well said.
If you need to share data with coaches, athletes, sports medicine professionals, as I said earlier, make sure you develop the skills to make that data presented in a simple and meaningful way. Okay, and as I said earlier, please use that data you've collected to confirm the decisions that you're making rather than using it for the basis of the decisions that you're making. Okay, what matters most is what you see with your eyes and what you talk about with your athlete. Okay, always remember, watch your athlete, listen to your athletes. Okay, that is the first pillar, the first basis of your decision making. Okay, collecting your data simply confirms that.
Be the coach, communicate, collect the data in the right fashion. Thank you, Patty. Patty, last question for young physiotherapists. I mean, obviously, they go to university, they get a degree, they come out, they start working with teams or clinics. Somewhere down the line, they lose track of what they're doing, and they understand that their domain knowledge is not up to scratch. And a man in the mirror says something is missing. They're a little confused. The picture is a little hazy in the mirror. And you must have seen many, many therapists going through this sort of a wheel of life. And what is your piece of advice for them?
I haven't just seen many therapists go through it. I've been through it myself. Like, I think every professional who tries to be the best they can goes through this. There's a few things for me. The first best bit of advice I can give to a young physiotherapist is to find a good mentor or a good boss, believe it or not, in the early part of your career. That is so important. I think how you initially practice the physiotherapy profession in your first few years of practice, they're the most important years of your journey. And I think you need to work with physios who are senior, who are humble, who are inquisitive, very importantly, are generous with their time, their intellect and their expertise. And you need to work with people who genuinely want to improve the profession, okay? Because it's the same as every profession, but particularly as a physiotherapist, you will become what you surround yourself with, okay? You lie down with dogs, you wake up with fleas, unfortunately, okay? If you do this, okay, your problem-solving skills and how you execute your technical skills will improve and evolve over time. You know, I look at how I manage patients, athletes I work with nowadays, and I promise you it's very different to what I was doing 5 years ago. And 10 years ago, it was very different to what I was doing 20 years ago. And that's how it should be. And if that's not happening, then as you said, you need to take a look in the mirror. The second thing I would say is you need to become very good and very thorough. And this sounds very basic, but not a lot of people do it, with your subjective examination and your clinical reasoning that is based on your subjective examination. For me, clinical reasoning is the number one skill that a good physiotherapist requires, okay? So it's having the ability, okay, to take all of the information from the subjective examination, okay, and use that to prioritize what you're going to do in the objective examination, okay? The techniques we use are reasonably simple as physiotherapists, okay? But understanding when and how to use these techniques, that's not simple, okay? If you ask the right questions of your patient and allow them to talk, because so often we interrupt them, I promise you at least 80% of the time, you will have a good idea of what is wrong with that patient before you touch them, okay? That allows you to target your objective examination so much better, and that allows you to put together an effective plan for the management of your patients. Most physiotherapists I deal with, they have the technical skills, they have the knowledge, okay? Okay, the one piece of knowledge that I would say that young physiotherapists really need to go back and work hard on, and all physiotherapists, is anatomy, okay? For me, anatomy is the foundation of subjective, sounds crazy, of subjective and objective examination, okay, and of assessment, and of all techniques that we use. We need to understand our anatomy so much better than what we do currently, okay? That is a huge thing for me. There's so much research out there, okay? Some great, some not so great. I think it's important that young physios need to understand how to evaluate new information that presents itself in the forms of research, okay? There's so much out there at the moment, and in the fields of bone stress injuries, muscle strain injuries, tendon problems, knee, low back, shoulder injuries. It's often hard to keep up. So, you know, one of the things I would do if I was a young physio now, I would form a group or a collective where you meet once every 2 or 3 weeks and we each present a different paper or a piece of research, okay, or some work from a course that you've been to, and discuss, you know, the implications of this, the limitations of it, but most importantly, how you can apply this work to the patients that you're working with. I think it's really important to critically evaluate the research. And what I mean by that is you just don't believe everything that's out there. I just don't believe that the latest is always the greatest, but you really need to look hard at the methods that people use and the statistical analysis that they've used in their studies, and then decide, whether the conclusions that they've come to in these studies are, reasonably, how will I put it, reasonably correct based on the interpretation of the results that have come out of the stats and the methods of the studies. So, like I said, the latest is not always the greatest, but again, with young physios, for me, it's the same thing. You need to understand your context as well, and you need to challenge yourself. Identify what you enjoy and what you're good at, and pursue this, and spend time talking to people that are out there. Spend time looking at journals, listening to blogs and podcasts and YouTube channels. And if that means going back to university or doing some short courses, please do it. The other thing with young physios is it's amazing how much better athletes, patients in general, seem to do when you assess patients every treatment that they turn up at. Okay, I think that gives us a very, very good idea about what the treatment we have done, what you have asked them to do from an exercise point of view, whether it has helped them, whether it has hindered them, whether they've plateaued, and whether you need to maintain their level of loading or increase their level of loading or back off on their level of loading. I always say assess and reassess. It is a huge, huge thing.
So Patrick's pointers here are: get your basics right on the button, reiterate your anatomy and physiology. I say the same for the strength and conditioning coaches too. Without the foundation knowledge, it's almost impossible to build the flows on top of it. Patrick, you nailed it. It's your ebb and flow today was just brilliant, and many thanks. And it was an amazing interaction. And young physios and SNCs will benefit immensely out of this podcast. I'll send you the link shortly, and also keep looking for the YouTube channel. I'll put everything together and send you the link, Paddy. It was an absolute pleasure in hosting you. Brother, see you soon, and have a great year ahead. 2020, we had shitty times. 2021, keep rocking, Paddy.
He's hoping 2021 is better, and thank you very much, and I really enjoyed it. Thank you so much, Basul.
Thank you.
Thank you.